Hello, welcome to this series of short videos on the methods behind guidelines from the Technical Support Unit at the University of Bristol. I'll be talking you through an important consideration for meta-analysis and network meta-analysis, heterogeneity. To recap, a pairwise meta-analysis estimates the effect of A versus B from multiple head-to-head randomized controlled trials. Network meta-analysis estimates the differences between all the interventions in the network, so you can see the effect of B relative to A, C relative to A, and so on. In the evidence report, where it discusses meta-analysis, you may see something like this. In the base case analysis, both fixed and random effects models were fitted to the data. The random effects model had a better fit, with a DIC of 225.9 compared to 257.32 for the fixed effects model. The random effects model had a total residual deviance of 31.4. This corresponds well to the total number of trial arms, 32. The between-study heterogeneity was 0.56, with a credible interval of 0.31 to 1.1. This is taken from a network meta-analysis performed for the Guideline for Management of Type 1 Diabetes. We will go through what the estimate of heterogeneity represents and what it causes heterogeneity. We will cover different approaches to model heterogeneity, the difference between fixed and random effect models, and how they relate to heterogeneity. Finally, we will look at how you choose between the different models. Where studies give different estimates for the same treatment effect, over and above what we would expect by chance, we say that there is heterogeneity. In the graph here, we can see that whilst most trials suggest that the effect of exercise might be to reduce depression, there is considerable variation in this. We measure how much variability there is around estimates of the same intervention effect from different studies using the between-study standard deviation. We can check if there is heterogeneity by inspecting forest plots or using statistical tests. In pairwise meta-analysis, the Q-test can be used, and in network meta-analysis, the fit of the models that do or don't assume heterogeneity are compared. You may see the DIC statistic reported to do this. Heterogeneity is caused by differences between study characteristics that change the relative effects between interventions, things that interact with intervention effects. When we combine evidence from different studies in a meta-analysis, we make the implicit statement that the studies are similar enough to be combined, and there are several reasons why studies might give different results. Studies might provide different intervention effect estimates if the participant population varies. This might be because of disease severity or stage, or which previous treatments patients have had. It might also be because of a coexisting condition alters the effect of the intervention, or because the definition for diagnosis of the condition has changed over time, so patients in newer studies are not the same as patients in older studies. Heterogeneity may arise if the intervention of the same definition differed between studies. The mode of delivery may itself make an intervention more or less effective. The intensity or dosing regimen may differ from study to study. Where active interventions were compared to placebo, we need to think about whether all forms of placebo are equivalent. Be careful where placebo is lumped with other passive measures, such as usual care or no treatment, as this can introduce heterogeneity. Heterogeneity may arise if the outcomes differ between different studies. Different studies may report at different follow-up times or on different measurement scales. They may use different thresholds when defining outcomes, or the definition of the outcome may have changed over time, so outcomes in older studies differ to those in newer studies. Heterogeneity may arise when some studies are biased due to flaws in their design. Smaller studies often give more extreme estimates than in larger trials. If we find evidence of heterogeneity, what can we do about it? Ideally, we would like to explain it so that we understand the variation in the evidence. We can do this in different ways, depending on what it is that might be causing the heterogeneity. We can perform subgroup analyses, which present results separately for different groups of trials according to characteristics that may be causing heterogeneity. For example, here we see that trials that reported before 8 weeks found a slightly bigger effect of exercise on depression than trials with longer follow-up. If trials differ in a numerical characteristic, such as follow-up time, we can perform a meta-regression to estimate the effect of the follow-up time on the intervention effect estimate. Here we see that the effect of exercise on depression reduces with longer follow-up. If we suspect that some studies, for example the smaller studies, are biased, we can attempt to correct for this in a bias-adjusted model. Here we can see that adjusting for small study effects gives more conservative estimates of interventions to prevent fillings in children, particularly the varnish intervention at the bottom of the plot. However, we may not be able to fully explain heterogeneity using these methods. To explore any remaining heterogeneity, there are two different models that consider the intervention effects in different ways. These are called fixed and random effect models. If we use a fixed effects model, we make the assumption that the only variation between the studies is due to chance, sampling error, and estimate the common true effect, shown here with the red line. The random effects model assumes that all the intervention effects recorded differ, but that they are all examples from the same common distribution, represented here by the grey curve. We use the curve, the distribution, to get an estimate of the effect of drug A versus no treatment, taking into account the heterogeneity between studies. Having fitted both models, we need to decide which to use. We can use the model fit to look for whether we should account for heterogeneity. If the random effect model fits better, this shows that accounting for heterogeneity is appropriate. If there is evidence of heterogeneity, we should use the random effect model. We will see wider uncertainty intervals around our estimates of intervention effects because we are specifying that there is more uncertainty in the estimates from the trials. If there is no difference in fit between the fixed and random effects models, then this suggests there is little heterogeneity and we prefer the fixed effect model because it gives more precise estimates. Heterogeneity arises when there are differences between the studies in our evidence set that change the intervention effects. It should be explained if possible, and if there is still evidence of heterogeneity, the random effect model is most appropriate.